Good evening and welcome to the IMA Weekly Show. I'm Dr. Elizabeth Mumper. My specialty is pediatrics. I'm a senior fellow with the IMA. Thank you so much for joining us live tonight. As a pediatrician, I'm very excited about the significant shift in U.S. vaccine policy, driven by renewed attention to the science, transparency, and an emphasis on child safety. So, recent actions by the Advisory Committee on Immunization Practices, also known as ACIP, this has sparked important conversations across the country. Before we introduce tonight's guest, we want to begin with a short clip from Aaron Seary, who's an attorney who presented to the Advisory Committee on Immunization Practices. The clip comes from a December 5th ACIP meeting, day 2. Mr. Seary addresses the importance of depoliticizing vaccines and shares his perspective on how policy, mandates, and public trust intersect in the current vaccine landscape. So let's take a look.
Mandates make vaccines political. When you take away somebody's right, you have made it no longer just a medical question. You've made it a legal one. You've made it a political one. When you argue vaccines should be mandated and somebody's rights should be taken away on the basis that a vaccine is safe and effective, you've now made the safety and efficacy no longer just a medical question. You've made it a legal question. You've made it a political question. That's probably in part why you find me here today as a lawyer speaking about this topic. When you mandate vaccines and you eliminate exemptions, you destroy confidence. Look at countries like Denmark, numerous other European countries, many other provinces and other developed countries. They don't have mandates, and they have very high uptake rates. There's far less controversy there about vaccines. There's no controversy in America about maternal screening. I didn't hear anybody talk about the concerns that people would be issues with maternal screening. Why? Because nobody's mandating it. They're recommending it. They're encouraging, they're persuading on the merits. And who do mandates impact? They impact not those who want to get the products, they impact those who most need to avoid it. And the reason I bring this up is because what ACIP does, and then what the liaison members do, filters down often into mandates. Directly by some of the liaison members and indirectly by what the work of this committee does when they make routine recommendations. And those folks who most need to avoid their products, what happens to them? Because oftentimes, and these are folks who contact our firm who are injured by a vaccine, those in the medical community, and I've heard some of them today and yesterday, they just pretend like they don't exist. This vaccine's safe. As if the father who talked about this child dying, how about the parents whose child died of a Hep B vaccine who was compensated not long ago in the VICP program, not on the basis of a table injury, not on the basis, as I heard earlier yesterday, of some kind of, a settlement, but on proving the vaccine killed their baby. It was a newborn. It was just given the Hep B on the first day of life that died from that vaccine. But the medical community often, to avoid vaccine hesitancy, does not give. Those folks feel like they're as if they don't exist. Every one of them, then they get kicked out of school, kicked out of their jobs. Things are said about them that are not always very nice. And those are the folks who then go and tell their stories. And their stories then can result in what folks describe as vaccine hesitancy, but they're really people who are trying to be heard, and mandates are the precipitator for what often results in that. And so liaisons, what I would urge is that for the liaison members in particular, to adopt policies that provide that they should persuade on the merits of these products and not coerce folks to do it. I'll wrap up in a minute. And I think that that's critically important if they want to increase vaccine confidence. After all, they have billions of dollars of federal government money and state health agency money and of their own money to promote these products. So they should be able to persuade on the merits.
So, as a pediatrician, I am so glad to see us talking about issues of vaccine safety now. I've been watching the ACIP meetings for many years, and the one that I just watched a week or two ago was extraordinary because there was so much debate and a lot of interchange, which is different from the past where the CDC would present and there were frequently just unanimous votes that didn't really involve much formal discussion. So, with that, let's bring in tonight's guest to help us better understand what's changed and how the ACIP committee approaches these decisions and what it means going forward. So, I'm thrilled to introduce Dr. Kirk Milhoan, a pediatric cardiologist, a senior fellow with the IMA, and we are thrilled that he is the newly appointed chairman of the Advisory Committee on Immunization Practices. So, Dr. Milhoan, thank you for being here and for joining us for this important discussion.
Thank you for having me. It's a pleasure to be here.
I admire you for taking on that role, Kirk. It's really awesome. Before we get into the specifics of the recent ACIP vote, can you describe the overall approach you're taking to evaluate vaccine safety and restore public confidence in this committee?
Yeah, so I think the overall view is that we want to make sure that the benefit of the vaccine is as high as possible and the risk is as low as possible. This is not a treatment of someone who's dying. This is a well child who we're trying to prevent something that they may or may not get or be exposed to. So our standard for making sure there is very, very, very little risk and knowing it as best as we can is very important when we're doing preventative measures, even more so than when I might use a riskier drug if I have a child before me who's dying, right? That allows me to generate a little bit more, accept a little bit more risk. But when we have a beautiful, healthy child or baby in front of us, it is really incumbent upon us to make sure that patient is considered. And I think that's one of the big discussions that we'll probably get into is much of what the committee is going for is we're trying to return back one of the most important foundational ideas or concepts in medicine, and that is first do no harm. I have a relationship, a very sacred honor with my patient, and my job is to look after that patient. It's not necessarily considered about what the public health is around the world. My first obligation is that patient. And so there is a collision that happens between public health and doctor-patient relationship that is at tension. And that needs to be discussed. And that needs to be understand that that's a tension. When you look at how do I keep a population safe, that is not necessarily always in the patient's best interest. Right. So that's how we're looking at it. We would like to you're going to hear a lot of conversations about shared decision making as we move away from recommendations, because I cannot recommend this as this is good for everybody. We know this, every medicine, any intervention we use, and especially when it's injected, right? We bypass a first pass clearance through the gut. We need to make sure that risk is as low as possible, and we know that it's truly going to benefit the patient. So we're trying to bring things sort of like, I think it's skewed a little bit too much to public health, and we started ignoring the doctors and the patients. That especially happened during COVID remember that I've always been able to get exemptions for persons. I never was questioned on an exemption. Let's say I had a patient come in who had a very strong history of allergies and bad responses to a certain vaccine. I write an exception. It was never questioned. I had never had that question ever before. I'm sure you've done that as well, Dr. Mumper. You've had lots of kids like, oh, this is a really concerning family history. I'm going to give them exempted from that. But in COVID, they were like, you have to tell us why it's an exempted. Wait, I have to divulge personal health matters to the school secretary of why I'm doing something? No, I'm the physician. I have a basic obligation and a really a confidential responsibility to keep their medical conditions between us. And then they were just saying, we won't allow exemptions for this or this or this. So what we're trying to do is we felt like it tipped over, and we're trying to write it back to a equilibrium that's going to flow back and forth.
Well, I'm so glad you're in that position. I really appreciate your perspective. First, do no harm. I think there's been a default assumption that vaccines don't harm anyone. And you and I both have seen cases where people were harmed. As you say, any prescription we write has the potential to hurt people. Have to be honest about that and discuss the risks and the benefits. So there's been a lot of discussion about the need to depoliticize vaccines. And now you're the ACIP chair. How do you separate the scientific reviews from political pressure that you must be getting when evaluating recommendations?
Well, I think we all have to be honest that we're all influenced by a lot of different pressures, right? There are pressures that come from one side of the Senate, one side of the Congress, the other side of the Senate, the other side of the Congress. There are statements that the executive branch makes. These are all different pressures. We have a press that has opinions of what the committee is doing and should they be doing it. So those are all pressures there. I come to it as I try to bring it into, I'm a pediatrician, I'm a pediatric cardiologist. I am here in defense of the child. That is primary. They will have other people who are in defense of public health. I am here in defense of the child because I think that that is first and foremost, especially in a preventative medicine type of atmosphere. Are there pressures? Yeah, I will tell you, I haven't felt any pressures in terms of what I'm getting from an administration to act in a certain way. I have not received those at all. And we're making every effort so we can truly be independent. Because I think there are some people who think we haven't gone far enough, and some people think we've gone too far, and we've probably made people on both sides pretty angry.
Well, again, I admire you for taking up this position because we need people who advocate for the child. There are plenty of people advocating for big pharma and plenty of people who've been advocating for public health for quite a while. So let's talk about what changed with the recent hepatitis B guidance. I was so thrilled at the way that committee was that meeting was run. Your colleague, Robert Malone, I thought did a masterful job holding that meeting. ACIP doesn't issue mandates, but it makes recommendations to the CDC. And in the past, many physicians have acted as if it was on the CDC schedule. That's what they had to do, which is really not the case at all. What changed in the guidance regarding the hepatitis B vaccine for newborns under 2 months of age when the mother tests negative? And can you talk a little bit about the rationale for why the committee supported an individualized approach as opposed to just the universal recommendation?
Yeah, so take it back a little bit, a step back, is many of the discussions and the recommendations from ACIP and whatever the CDC would recommend, that dictated funding. That dictated whether Medicaid would fund it. It dictated whether CHIP would fund it. It made whether vaccines, the VFC, the Vaccines Free for Children, would cover it. So each of those sort of different pots of money. And we were really concerned about the idea that our recommendations were not just being used as recommendations, but they became mandates for whether you could attend a school, whether you could go to college, whether you were able to do this, a daycare, other things. And we much like Aaron Siri had said, if you look at many of the other countries, they don't use their recommendations as mandates. And so once again, we felt that was a breach of doctor-patient relationship. And so we wanted to back away from sort of the authoritarian public health view and make it more, if I want to give somebody a product, I want to be able to tell them what the benefits are and what the risks are and convince them by my medical and scientific and knowledge of the child, as opposed to just saying, well, you just got to get it to go for them to go to high school. So that was the foundation, is a lot of the decisions we were making, we wanted to make sure they weren't mandates. So, but what we wanted to do is take the onus off of the child. So in 1991, there's an article in the New York Times, you can look it up and see it, but they described why they went to universal recommendations is because they couldn't get uptake in the adults who most needed it, who were at risk in high risk behaviors, and they couldn't get the uptake. And so that was really what they did, is they put the weight of that responsibility not on the adults, they put it on the newborns. And you know, Dr. Mumper, we have a certain sacredness of the neonate. Those first 6 weeks of life, we don't like to do surgeries, we don't like to give medicines, we don't like to do anything. We don't want a cold medicine, we don't want Tylenol, we don't want anything. We want to see how those babies are doing. They're so fragile, there's so much about them that we just have to we just sit in awe of them. You don't want sick people around them. So this was quite an onus to put on the neonate. And it wasn't, and they made it for everyone. But we're also on the committee trying to get back to more of a risk-based approach, individualized approach, shared decision-making with the family, and say, okay, what are the risks? If this is a low risk, let's move it out. We're one of the few countries in the West that does newborn dosing. So as we talked about, and we looked at the data and we considered, so even if you get a simple fever from a vaccine, which often you'll get a mild fever from a vaccine, in a neonatal period, that sends us down a road typically of a sepsis workup. And that would be blood cultures, or it might be an overnight stay in the hospital, might be urine cultures, might be a chest x-ray, many other things that go on. And so what we said is, you know what? If the mom is negative, and we know the mom is Hep B negative, then there's no reason for us to give a dose at birth. And that's all we said. We didn't talk about those who had unknown. We cleared those out. If mom is positive, if the doctor and mom are unsure, if there are other contributing factors that people want to give it, up to them. But what we recommended is, you know what, let's let people decide. This is a disease largely transmitted by body fluids. And so that risk typically doesn't start until more like the adolescent period. So what we said is, we don't recommend a birth dose if mom is negative. The earliest we would start is 2 months. That's when all the rest of our vaccines start. That's where a lot of the pentavalent and hexavalent vaccines are. And some of them in other countries have Hep B in that. So we wanted that to be the earliest start. And then give people, talking with their doctor, patient-doctor relationship, decide if they want to give it. And if they do, when do they want to give it? We had some data shown to us, very clear, that if you waited later, you had a little bit better uptake of and a more robust immunity by looking at the antibodies to the vaccine. So we wanted let doctors to have and to be able to explain those benefits and risks to the patient. What we did do and made sure of this, and it takes a lot of strange language and extra language, is to make sure if doctors wanted and parents wanted to do it, it was still going to be fully covered. We didn't take away any of the freedom of anyone except to take it outside of a recommendation and allowed for shared decision-making. And we used the word suggested not to start before 2 months. That's what we did. Now, what has been said in the press and what has been said by societies and other things has made it look like, oh, we just want children to get liver cancer and they're going to die and all these horrible threats. That was not our intention. That is and so we feel very, very comfortable with the safety, or really the low risk patient doesn't need a vaccine with a risk, because every vaccine has a risk. Every treatment we use, antibiotics, whatever, has a risk. So we've taken away that risk from the neonate, given families and doctors the freedom to do as they wish, as their conscience, as the medical history leads.
Yes, Kirk, that's so interesting. As a pediatrician, I never really routinely gave the hepatitis B vaccine at birth for all the reasons that you're mentioning. And I ruined our hospital statistics as a result of that because we didn't get 100% uptake because of me. But it's very odd. Most cultures take a moral position that the adults are supposed to sacrifice for the children, not that the children are supposed to, take on an extra burden to protect adults. So it's always been a little odd from that perspective. But it sounds like this change is reflecting a shift in the one size fits all guidance, particularly for newborns, to what you've referred to as shared decision making or very good doctor patient discussions about making joint decisions and abandoning the doctor as the authority model and going more toward a collaborative model.
Yeah, exactly. Exactly.
So you've emphasized the value of having diverse committee members on ACIP with wide types of experience. Why is that especially important in this case? I thought it was fabulous that we were having these debates at the meeting instead of everyone seeming to be of like mind. But give us your thoughts as the chair.
So, medicine isn't exact. I mean, it's called the art of medicine for a reason. And depending on what your experiences are, before you became a doctor, what your experiences are as you're training, as you learn things, you often have certain things that are very important to you. Let's say if you saw someone die from, a 20-year-old die from liver cancer from hepatitis B, that would influence how you looked at kids. If you saw someone who died from a vaccine injury, that influences how you look at things. So it's important that we have a broad breadth of people who come with different, and I'll describe them. We each have a confirmation bias. We look at the world in a certain way, and it's a bias, and we all have them. And so it's nice to get lots of people who look at the world from different frames of reference so we can talk those things out. This idea that there's settled science in medicine, it really needs to come out of our vocabulary. That isn't science. Science isn't settled. Science is observational. We're still looking at it. So maybe in your mind, you've never seen this, but you talk to someone else and they've seen something. So that's why it's good to have people with different experiences and who have different views of what they think is higher. Is it public good? Is it good for all? Or is it the individual? Lots of different opinions need to be expressed. In medicine, I love the pro-con debates. We debate vehemently in pediatric cardiology of what surgery is right, what the timing is, what is the best way to do it. Should we use this procedure or this procedure? Is this surgery? I see everywhere I go, my wife and I, who's a pediatric cardiac anesthesiologist, we love the pro-con debates. And I just came from the World Congress for Pediatric Cardiology and Cardiac Surgery in Hong Kong. And every day they had pro-con debates. Well, yeah. So this shouldn't be abnormal. It shouldn't be abnormal. And nobody should be afraid of this. I'm not afraid of the truth. And what I want is the truth if I'm wrong about something, I want to be there. I want to know it as soon as possible. Part of the good thing about having not a one size fits all, or we're going to look for 100% on every vote, is that we need to have that ability to go, wow, I haven't considered that. I haven't thought about that. Every one of these meetings, I'm thinking about new things and going, okay, what is this? How do I get to the bottom line of what I think the benefit is? And it's not necessary for society. I have to go, okay, what's the age? What's the influence? What are their genetics? What is their family history? Who's going to be living in the house with them? All of those things. And that's not just for hepatitis B. That's basically for the whole vaccine schedule. You can look at some people and they have lots of risk. These kids are going to be traveling internationally from 6 weeks old and on. That's a different risk than someone who's a homeschooled child in a rural community. Completely different set of risks. So I think I don't think we should. I'm somewhat shocked how much people are opposed to just having the discussion that there's a risk with a medical intervention.
Well, I think it behooves us all to remain humble because we've all done things that have led to a allergic drug reaction, for example, and people tend to accept that. But once you talk about vaccines, it's like you can't even consider the possibility that people might have side effects.
Yeah, I have a great
So,
example of this. So I have a child I took care of and then a close family friend. One was a child I took care of who had a staph infection on their leg, was given Bactrim because it was a MRSA, it was methicillin resistant. So MRSA, so the Bactrim was the right drug. And this kid developed ARDS, acute respiratory distress syndrome, from the Bactrim, needed to be put on a heart-lung machine for close to 3 months. They basically
wow.
were going to turn the machine off and let the child die because they thought this, and he just sort of perked up and lived. I got to be with him as he made it all the way through, and a wonderful little child now. I have another person, a friend of mine, very close friend of mine. In college, she was treated for a sinus infection, and the first round of antibiotics didn't work, and so they went to Bactrim. She developed Stevens-Johnson syndrome and almost died. I haven't stopped using Bactrim, but I can still be cognizant and honest about it does have risks. And it can have risks that maybe be 1 in a million, 1 in 10,000, 1 in 100,000, 1 in 1,000. I don't become an anti-Bactrimite
Right.
because I'm comfortable with describing the risks. And that's what we'd like to bring back is not that we know it all. A lot of these medications, we might be looking for side effects that are going to happen 5, 10, 20 years down the road. So we do have to walk humbly with what we're doing, and especially to a developing child, right? We just have to treat them differently, just like pregnant moms. Pregnant moms and children get treated differently. And with a humbleness and an understanding there's a sacredness, even like a deeper level of sacredness in treating pregnant moms and children.
I agree. So, when evaluating childhood vaccines, how are you um, evaluating and balancing all the population data that the CDC tends to come forth with versus the realities that clinicians like me see, where I have the concerns that, for example, a Hep B vaccine at birth might disrupt breastfeeding or cause pain or cause fevers that lead to a sepsis workup and antibiotics, which are then going to ruin the gut. So there's that constant tension you were talking about, and you're in the enviable position of being able to resolve that.
I think what's really hard is we look at things scientifically. It's hard enough to study a single intervention. It's hard enough to get a study designed where you can really have a true control. For instance, you would love a saline injection control because that'll have some site pain and some risk of infection and other things. You'd like that as a control. You'd like to have just one variable. But many of these products, as we ask for that data, and we say, can you go back to the FDA, can you give us the original approval data on this? And a lot of that is pretty disappointing. When we looked at hepatitis B, the data, we had no pure control. The only other control was using another hepatitis vaccine as the control group. And then they did 3 studies, and there was it was low power, just in the tens to hundreds of children that were looked at. And they looked for 3, 5, and 7 days. So if we start looking at vaccines, let me go just a little bit in the weeds here for this. And because I'm a pediatric cardiologist, because I travel around the world, I see a lot of rheumatic heart disease. So rheumatic heart disease is when your body is fighting the strep infection. And there's a protein on the strep infection that your body attaches an antibody to, but that protein is very much like the tissue in your heart valves. And so, especially on the second infection, your body really revs up to fight the infection, but then it can start attacking your heart valves. But it might be months to years to even decades before someone finds out what has happened. So when we try to make a vaccine, or we, the global medical community, not me, but when they're trying to find a novel protein that the body can make an antibody to, that will attack the virus or the bacteria, but it doesn't share a protein with any part of your body, or else it can cause what is called an autoimmune disease. That means is your immune system attacks your own body. You know this, Dr. Mumper. And so, but those don't show up right away. And so when we have, if we're just looking at Hep B, that would be nice if we just had Hep B and a control group. But now we don't have that. We have Hep B, and then we have the schedule starts, and then you add 2, 3, 4, 5, 6 more vaccines, which may not have good control groups to start out. We don't have really good data on what it is to have one vaccine versus 2 vaccines together versus 3 vaccines. Our first ACIP, when we looked at MMR and MMRV, so measles, mumps, rubella, and measles, mumps, rubella, varicella combined. So 3 or 4 together, always trying to do less harm to the child. So let's say if we can do those, and it was the first at the first dose, and they compared both of those, and they found that if you added the varicella vaccine to the MMR, then you had twice as much febrile seizures for the children at about 1 year of age. Febrile seizure is a diagnosis of exclusion after you've tested everything and done the workup to make sure they don't have encephalitis or seizures or other types of things. And it can last for 15 minutes. And when you talk to a mom, if they've had a child that had a febrile seizure, 15 seconds is too long. 15 minutes, you're thinking this is status epilepticus, and this is a big deal. And a mom will never allow a child to get another vaccine if they have a febrile seizure. They will be terrified of that. When they looked at it, in order to be able to get the varicella to work with an MMR, they had to use 7 times the dose of varicella in the MMR combined to get the same antibody reaction. And so, but if you gave them separately, even the same day, you didn't get this reaction. So what we're trying to say is sometimes they interact, but a lot of those trivalent, quadrivalent, pentavalent, hexavalent vaccines, when we start adding them together, we don't really have the data to say. It's almost like the toothpaste is out of the tube. And so how do we really study this? And so when you're trying to do very honest research, and there's a side that's saying, well, it's safe and effective, safe and effective. Safe and effective are not scientific terms. Risk and benefit, risk and efficacy, those are scientific terms. Safety is a subjective feeling to a risk that's been presented. So I have some people who are very concerned that their child might get a disease, very concerned. They don't want to, they want to do anything they can to limit that risk of their child getting a disease. I have other people, patients I know, they're very concerned about their child being harmed by a vaccine. Both of those are legitimate concerns. Both of those have valid concerns. But often they haven't been really discussed of what really the benefit is. What's the risk of getting the disease? What's the risk of getting a vaccine injured? And so it's very hard for us to really study this because so much of this has gone out and no one's allowing us to question it. And all we're trying to say is guys, as we look at this, can we think again? I like to, I'm sorry, I have lots of things to say. Dr. Mumper.
Keep going, you're doing great.
So I came up with it. I live in, sometimes part-time I live in Maui, and I have a lot of friends who remodel hotels. And a hotel might get remodeled every 7 or so years, where they update it, right? They need to paint the walls, they need to do things. And so some of these old hotels, I see they just get completely destroyed. And some of these old hotels, they never get updated at all. But if someone's really watching carefully, they'll realize times have changed, desires have changed, we no longer like light colors, we like dark colors. And then years later, we like dark colors and not light colors, and shade carpet, then firm carpet, then wood floors. All those things change. I look at the vaccine schedule as something that is like an old hotel. And you can choose, some people would like to blow it up and destroy it. And other people would say, no, it's not outdated. But I think it is outdated. I think we need to look again. So I'm of the view, I don't want to blow it up. I don't want to just set it. I want to say, how do we update this? How do we make it better? And how do we take away risk? So that's our approach, but it's not easy trying to untangle this web.
Well, your point that science is always evolving is a good one because we ought to apply the evolving science we have now to the vaccines, especially as you point out, since they're given to healthy people, healthy children and babies in order to prevent something that may or may not happen to them. So it's interesting that some national medical organizations who were invited to participate in the review chose not to and even publicly disagreed with the committee. And that's got to be very confusing for parents. So, how should parents deal with trust, transparency, differing viewpoints? It's a hard time to be a parent, I think.
Yeah, you know what I hear over and over again? Who can I trust?
Yeah.
Who can I trust? I guess the broad view I would say is someone who's willing to sit with you and answer your questions. And before you allow an injection into your baby, is that you feel comfortable that you've been explained what are possible benefits, possible risks for both not getting it and getting it. Right? Those are true. There are people who get a vaccine and don't get something that they could have gotten. There are other people who weren't never going to get a disease and got injured by the vaccine. So you have everyone on every side of this. But I think we need to get away from it's settled science, it's safe and effective, don't ask any questions. I think this requires some discussion. And as physicians, we're going to have to do something. We have to do something. There's a collapse of trust in doctors. And that's not just vaccines. That's across the board. My wife and I are seeing it in our work with children with heart defects. Patients are asking us questions. They're very, very concerned. I was just talking to a mother this morning in the hospital. How much of this medicine is my child going to get? He had a very concerning arrhythmia, a heart rhythm problem. How much is it? How much are you going to give him? 10 years ago, I would have never heard that question. One just recently, probably about a year ago, my wife was asked, I want to know every medicine my child is getting and what are all the side effects of them. In an anesthesia case, she gives lots of different medications. So I think find a practitioner who's willing to walk with you, understanding that I know 99.999% of the families I take care of, they love their child more than I do. And someone who's humble enough to walk with them, isn't afraid of asking questions, isn't afraid of a discussion. And you might walk away looking at things differently. That's okay. It saddens me that some of these liaisons, some of the big medical societies, they've walked away. We encourage debate. You hear us, we debate. We've had very few unanimous votes in this new group of ACIP scientists and doctors, which I think is good because we're dealing with things that it is not. There's nothing settled about this, and this needs to be talked about. And we have a now 10 to 20 to 30-year view of vaccines, and we're seeing some stuff that we have a lot of correlations. And so we now have to start looking at these correlations or causations and how many correlations are involved. And it's really hard because there's a lot of correlations with the changing health of children. And we need to be mindful of that.
We often hear from our detractors when we raise vaccine safety concerns that correlation doesn't equal causation, but we have these things called the Bradford criteria that you can look at to try to determine causation, and it includes things like temporality, the
Yeah.
timing, and is there a plausible mechanism? And I think those things have been largely ignored. So I'm so glad that we are in an era where we are having these debates. So, as we're taking a fresh look at the childhood vaccine recommendations, as chair of ACIP, how do you plan to ensure that child safety remains central as new data and technologies emerge? We saw this happen with the new mRNA technology for COVID, which I would argue was the same situation where they didn't test it in nearly enough children before recommending it to everyone.
Um, so this is something that I'm it's really big on my heart. And there's lots of things we need to do. But I think we need to be able to look at things again. There's a beautiful book called Think Again, and it talks about don't be afraid to readdress some issues. We're in a different time frame now. So, but the reason why most of the time we give boosters is not for the individual, it's for herd immunity. 1992, I was taught in medical school. The reason why we gave 3 doses of hepatitis B is because the first dose, about 40% of people seroconverted. That means they had a response to the vaccine. If we gave 2 doses, 75% of the population converted. And if we gave 3 doses, it got to that magic number of 95% converted. And that is considered herd immunity. Remember though, 1 in 20, 5% didn't seroconvert. Okay. So when people say, oh, they're covered if they get 3 doses, not necessarily. Okay? But the other thing was but when you talk about when I give it to a newborn, only a lot of data shows around 26% seroconvert with the newborn dose because their immune system isn't quite ready and it takes a while for it to get revved up. But if you're one of those and your child converted with the first dose, then why do you need the second dose? And why do you need a third dose? So we're told that the reason why we do 3 doses is because that's shown to be effective. No, what that was showed is that 95% of the people responded. And so I asked the question, why don't we allow, because like when I, as a physician, in order to work in the hospital, they wanted to see what my hepatitis B titers were. If they were high enough, I didn't have to get a booster. If they were low, they wanted to give me a booster. So what I would like to do, and I know that this causes a lot of consternation over this idea, but why can't we do it with kids? So if I draw blood, the risk of drawing blood is very, very low. It's painful and kids don't like it, but the risk is very low. Right? Giving a vaccine doesn't have a 0 risk. So why can't we treat like the doctors are being treated? And when I brought this up, they said, well, you can't do that. I go, well, we use it for doctors. Why can't we use it for kids? Well, we have no evidence that that works. Well, then why are we assuming that seroconversion in the population tells us that kids have confirmed immunity? Why don't we actually let moms know? So if we take an individualized approach, and now with our lab tests becoming point of care, one of the things I want us to have the discussion, I don't know exactly how this works out. But I want us to have the discussion is how many kids really need 3 doses? How many kids need 4 doses? Could we in low risk populations, could we do real studies for people who are willing to do it and do see if they seroconvert? And if they seroconvert, then we go, oh, great. We don't have to give you any additional doses. If you listen to people argue with me, they don't have any data to say this is a wrong idea. And we're already using it for adults all the time. So one of the ways I'd like to do is how can I limit risk? Well, if I could take away from 25% of the population or 50% of the population, 2 or 3 extra doses, while we're talking about stacking toxins like aluminum adjuvants, if I can remove some of that, if I can remove the total rate, that's what I'm interested in. I'm interested in looking at this again and saying, maybe I can cut this. And even the European schedule that's much smaller than ours, what if we were to cut that in half? And have the same benefit per child, but a dramatically different risk strategy. So that is one thing I'm very, very excited about. It's something I think with Jay Bhattacharya at NIH, it's things I think we can start looking at. And I think we have enough people that we could probably set up some really nice, well-designed trials. I think that the other things that we're doing is, okay, we need to ask these questions, right? We need to ask these questions. We see this correlation, we see this correlation, we see that, and a lot of these correlations have been there for a while. Tylenol correlation has been there a while. Aluminum adjuvants has been there for a while. A live vaccine versus inactivated vaccine, that's been there for a while. There's some very interesting data out of Africa by Catherine Bale and others that have shown some very interesting interactions of your immune system, whether it's a live virus or an inactivated. So I think what we have to be able to do is say, okay, how do we start sort of systematically going back and trying to figure out which are the vaccines that are probably the most risky to the child, and be honest about it. And we can be wrong. We could have said, wow, we really messed up with that. Just let's be humble and say, as physicians, we thought it was going to be a good idea, and it just turned out 20 years later to be a bad idea. Okay? So there are vaccine makers who make those free of aluminum. Why don't we set up a schedule that we have an aluminum-free schedule and allow people to choose to be in either one, and we can double blind it and we can do all those things, and say, we want to study it. Well, you can't do that. Well, why can't we do it? Right? Why can't we do it? So I'd like us to think again about so many of these different things. Timing. I think also we need to ask, they took off smallpox vaccine a long time ago. Should some of these come off? I don't know. A lot of people talk about diphtheria, talk about other things. We're in a different state of hygiene and water, health, our ability also to treat viral illnesses. What might have killed a kid in 60 probably doesn't kill them necessarily now. So I just think everything should be on the table. And then our sort of job is to try to, okay, what's my pet project? But with all the people who get together, you and I, if we talk about vaccines, we might have one I really like, but these other ones I really don't like. We all have those sort of things like, I really like this for a child, but I wish I could just push those off. That's the helpfulness of having a big group, is that you bring everybody's sort of pet peeves together and little darlings together, and then you go, okay, what do you think we should do? So that's how I'm looking forward to this. But as we're starting to look at the data and the holes in the data, I think we really are going to benefit from if Dr. Bhattacharya and the NIH can help us to design some really nice new trials and go forward with informed consent on your child may be getting this, your child may be getting that.
Kirk, we are so lucky to have you articulate those views and be in that leadership position. I didn't understand why so many people pushed back against the idea of hepatitis B titers. And when I was in practice, I had an analogous thing that I would do. Some of my patients would report an initial bad reaction to the MMR vaccine. And the second dose at kindergarten was initially added in because about 5% of the kids initially didn't have a good response, didn't seroconvert.
Yeah.
So if we were able to show that the children, and most of them, 95% of them, did still have lasting immunity. So they didn't have to take a second shot and risk a potential, another bout of diarrhea or behavioral regressions or whatever the initial case was. So that can be done, and parents are glad to have that data. I know nobody loves a blood draw, but I don't think that the arguments that, oh, the blood draws are going to be too administratively difficult for pediatricians, well, put on your big girl pants and, do your job. And it involves some thinking.
Yeah, and I think we're the technical aspects of medicine and like point of care stuff, where now you can do finger sticks where you used to have 5 cc's of blood. It's a game changer for things that we're able to do. And I agree with you. And you know what? It might really help a family member to go, you know what? I'm okay with one. We need to be very humble about what happened with COVID vaccine. The first vaccine wasn't really that bad. That second vaccine is what really caused the myocarditis in young males. that's where we saw it primarily after the second dose, and we often see that they did fine with the first MMR, but it's the second one that gets them. So this is just having an open dialogue and wanting the best for your patients and best for medicine, and to try to, I think actually we can really change, like if we take away mandates, and we can't take away mandates. That's state and federal driven. The ACIP has no ability to do this. We're an advisory panel, and so we advise the CDC, and then the CDC and the HHS have to decide what they want to do with what we advise them to do. But I think often if we get out of the way and let things settle out, and you take away immunity from drug companies, and you don't mandate things, you'll see what people think works and what people think doesn't work pretty quickly.
So, Kirk, I'm going to give you the last word about what takeaway messages would you want parents to have in the realm of informed consent, this concept of shared decision-making, collaboration instead of authoritarianism, and the future of the schedule and child vaccines.
But like I said, we're going to do everything we can to bring empowerment to the families and to the physicians to be able to talk about this. And what I really want this is to no longer be a taboo subject. I don't want it to be one where there's name calling associated with it. These are just parents they love their baby so much, and they don't want anything they hate the fact that they have to get anything done to the baby. So the less you can do, the less you can make the baby cry, all those kinds of things. I think that just have a nice discussion with them. And to my pediatrician colleagues is that I'm not against vaccines. I don't have this thing that I have to blow up the whole thing. At the same time, I have a very, very sacred honor to doing no harm to the child. And so I would encourage people that we need to have this discussion. I want AAP and AMA and all those other liaisons who don't want to come to the ACIP. I welcome them. Please come. I want to have this discussion. And bring your data. Bring your data, and let's sit down and have it. That's what we do in our work groups. We have both sides come and present stuff to us, and we're talking it all out and trying to do the best we can. But what you're going to see from this is you're going to see a little bit of a change, that we're going to be in favor of a doctor-patient relationship. That's going to take higher credence over authoritarian public health.
And I want to put in my votes for taking the bullying and the shaming the parents out of the vaccine discussions. And unfortunately, that I think has happened far too often. So, Kelly, I think we have come to a good place to maybe look at some questions and answers for Kirk.
That'd be great. I mean, you both talked a bit about how parents can make better decisions. One question that Ellen O brought up was, it sounds very reasonable, and shared decision making sounds very reasonable, but what do we do given that many medical journals and organizations are corrupt in some of the data that they reference? And so is the information that people are having in these discussions accurate?
Yeah, that's a whole nother issue that's invaded all of medicine. When I was in graduate school getting my PhD, there were no advertisements in journals. In fact, journals were pretty expensive. It was hard to get first-hand journals or reprints of journal articles. But now we have direct patient advertising on TV. We have it in not only medical journals, but all sorts of print media. And so I think people have been concerned as this stuff, as information comes out, is that who's doing the medical studies? Are they truly independent? Who has to pay for them? Is this a industry-driven study, or is this a university-driven study that is outside of industry influence? This is where I think with Dr. Bhattacharya at the NIH, it's very important we have an opportunity for the government to come in and say, we're going to be the arbitrator here and try to remove that, because there are lots of situations. I mean, these things are coming out with the FOIA requests regarding what we're seeing in the FDA, that they just came across, and they found new data about myocarditis deaths in young boys. So we need to get to a place where we can trust the data. There's something about statistics and lies.
Mm-hmm.
And what they'll often use is they'll use a relative risk versus an absolute risk. And I think if a lot of patients saw the absolute risk of harm from a disease, rather than the relative risk, they would say, okay, it's worth the risk. So there's a lot of honesty we need to bring back. We need to get our reputation back as physicians. And that's what I'm trying to do. All of us on the committee, we had to sign. They looked through all of my finances. They looked through all of my stocks. We had to sell a Walmart stock because Walmarts have pharmacy. So we had to sell a Walmart stock. But because I wasn't going to be onboarded until I had nothing that could influence me one way or the other. And I think that open book, physicians, studies, information, we're going to have to open up ourselves to bring back some trust in us, and we're going to have to earn that trust.
Well, you talked
And
about, I think it was really troubling just how the trust in physicians is just at such a low right now. But what you also spoke about was finding a physician and doctor that can be more humble and talk to you and have that open dialogue. And I know that at IMA, we're trying to do a lot to help empower the patient or parents and be a trusted source, so parents can have some of the information to ask those good questions or be a source as well. I know even on our Smart Moms Ask area on our website, we've had many of the pediatricians on our team speak to different points of view so they can quickly get some of those questions answered.
Yeah. Yeah.
And Kelly, I'd
Yeah.
just like to add that I had the pleasure of hearing Dr. Bhattacharya in person about a week ago, and he talked about how in his NIH there was going to be replication of
Mhm.
studies. He found that a lot of the recommendations the government has made in the past were based on one study that might have been done by a university with an underlying agenda or a pharmaceutical corporation where their results were never replicated by an independent source. So I thought that was fantastic to bring replication back to science, which is really the way that you start to get closer and closer and closer to the truth.
You bet, and a really important point. Bob Isaacson asked, is there any research or evidence on the harmful effects from administering multiple vaccines in the children at the same time? And I know that even Trump, tweeted out that they wanted to look at the entire vaccine schedule. How would you address that? But I guess this could go both to you, Dr. Milhoan, and to Dr. Mumper.
Yeah. I think that there's unfortunately there's a paucity of data.
Mhm.
This actually was highlighted in a 2018 ACIP video that they talked about how much knowledge was known about these multiple doses. And they said, well, we really don't have any data, and we just assumed if they were okay by themselves, they're okay together. Which was the first assumption might not have been right anyway, and then they doubled it. So this is where I think we can do, until we have the data, is there a way that I can give a child the same protection with less doses? I'm going to do that, right?
Right.
So that's why I was talking about titers. And are there maybe there are clinical ways, like Dr. Mumper said, this is very true. Did you get a good fever? Did you get a response? I mean, when I asked that for COVID kids after they had the vaccine, if they had chest pain and a really bad response, then it changes how I look at them clinically as opposed to the person who had no response. So are there clinical indicators that would be surrogates for a reaction that we would probably maybe not have to give the second dose? We might not even have to give blood. So those are all things that I think that need to be done. The other issue that's really at play here is corporate medicine versus individual medicine. And it is when you're part of a corporation and you're part of an electronic medical record and you're part of all these other things, there are pressures and insurance companies want this and they want this, and there are a lot of different incentives, and don't have too many red dots on your patient, or it's a problem. So that's one of the difficulties too. I really do want to make a plea for. There are a lot of really, really honorable physicians out there that even now I'm getting comments that I would love to be able to speak out, but I'm in this corporate situation and I have kids in college and I can't get out of it. I don't have a way out. So this idea that we can't speak about this is, there are a lot of people who know, but they feel trapped because they put their whole life into this career, and there are very few independent jobs. A lot of them, hospitals are building up and more corporations are buying these practices. So we have a lot of facets to deal with at the same time to try to be able to get make some headway here.
The other concern I have about multiple doses at one time is the adjuvant load, particularly aluminum, which is a known neurotoxin and a known inducer of autoimmunity. If you're studying animals and you want to make them autoimmune so that you can figure out a treatment, you give them aluminum. So there are some colleagues of mine that have looked at the amount of aluminum and compared it to EPA recommendations, and are concerned that a child in the first year of life who follows the CDC schedule absolutely to the letter may be in chronic aluminum toxicity with little bursts of acute aluminum toxicity. So I think that we need to make sure also that our vaccines are as clean as possible. You do need an adjuvant of some sort in order to stimulate a response. But given the fact that so many kids now have neurodevelopmental problems, and given the increase in autoimmune disease over the last couple of decades, I do think we need to look at that as one possibility.
Yeah, and that's what we were looking at. So this is why we brought it up in our last, and we'll continue looking at it, because this is something that probably there are ways to get away from it. And there are some very interesting studies. If you look at adult levels of aluminum, then they still spike over it. But if we look at, and this has to be age dependent, because renal clearance of aluminum changes with time, especially very young, are much different. And so these are things that really need to be looked at. There's some very interesting studies, especially as we start looking at activating your immune system early on, where you have eczema and asthma and other issues are very concerning. So it's not just the severe issues. We're giving these people chronic illnesses that they might have the rest of their life. And if there's a way for us to get the same benefit without causing this harm, then we should do everything we can to figure that out.
And we have so many questions here. We could probably have just a whole open dialogue with you all. So we might need to think about that on our calendar. But before we wrap up and go into closing questions, I wanted to ask from Marilyn S., is there different, on a different vaccine note, there was a bit of a U-turn this week with the FDA and an internal memo that was out about putting out a black box warning on the COVID vaccine for children. And then all of a sudden, it seems like there's some backtracking with McCary on that. We don't exactly have clear announcements on that. Do either of you have any insight on that, and what are your thoughts there?
You have a death signal on this, and it's concerning. Usually, if you have a death signal, that gets a black box warning.
Right.
So,
and I don't know what's going on with Dr. McCary, but I do have confidence in him. But if I were the one in charge, I would put a black box warning on, because
right.
I did a lot of in-depth research on that shot for kids, and the risk of COVID itself was so low that any death is higher than the risk the child would have initially. It's a risk of like 1 in 1.7 of mortality, and the shot risk is higher than that.
Right. I know that's something we've spoken about pretty broadly, so I know we have a lot of great data to support that as well. Well, before we leave, there are a lot of questions about circulating measles strain. So I don't know if there's anything that either you can speak about, but that Lori asked, the measles strain that's currently circulating is D8, which is from India, Nepal area. Since America hasn't seen the strain, can this account for a huge amount of people getting sick? And then someone else mentioned, in South Carolina, seeing cases they believe potentially linked to India. What would be
Um,
your comments on circulating measles?
well, I can tell you at the last ACIP meeting, that Tracy Beth Hogue from FDA was showing the results from the vaccinated versus unvaccinated. And so there's some strains that aren't covered by the vaccinated and they still get measles. But the majority of patients right now that are getting measles in this current season is the unvaccinated. And so there seems to be some protection for those who've been vaccinated. But like I say, with all these things, we're always trying to look at, okay, what is the disease process? What is it like now versus 20, 30, 40 years ago? But yeah, so we're in a new situation too because of travel. So 30, 40 years ago, we didn't fly like we do now. When we did flu vaccines, it was looking at last year's flu in Asia, and that's how they came up with the flu vaccine. Well, people fly so much. There isn't really a seasonal variation around the world as much as it used to be. So I think we have to incorporate when we're looking at risks, and we have to incorporate how much international disease comes to us now as just part of normal, and it's not something that might only come occasionally. So yeah, these are all very good questions that no one should be afraid to look deeply, and no one should be afraid of what the data show.
And I'd like to put in a plug to help all the clinicians out there. Remember that vitamin A, high dose vitamin A, is an excellent treatment for measles. And unfortunately, when the child does present with measles in this country, it seems like everybody just sort of throws up their hand and says, there's nothing really we can do about it. High dose vitamin A is excellent. And then I saw a question pop up when I made the comment about if I were Marty McCary and had to decide about the black box warning, I would put the warning in. But if I were queen, I would take away the mRNA platform for kids for COVID. So yes, I am not in favor of those shots for kids. And I wrote a book about why I felt that way.
Yeah. Well, before we wrap up and go into closing announcement, anything that either you, Dr. Mumper, or Dr. Milhoan would like to add before we close? And thank you for everything tonight. It's been really informative.
I just saw a question pop up about the dose of vitamin A. So 200,000 to 400,000 units for 2 to 3 days is typically the ballpark.
The only thing I mean, we talk about all these things, and I think everything needs to be on the table. There was a leaked memo that Dr. Vinay Prasad was talking about the effect, our study of how we do flu vaccines and stuff like that. That this all needs to be on the table. Right? There was a Cleveland Clinic study showed negative 27% efficacy. We need to just be honest with people of what the benefit is and what the risk is, and we need to get back to that.
I appreciate
Honest
all of your
medicine sounds like a good
candor.
slogan.
Yeah. Yeah, I appreciate we're so I think we're fortunate to have you in your role, Kirk, and we have a few other fellows that are contributing as well, which is amazing. We've got people at the table that are bringing up these issues and having this open scientific debate that we've been desiring for a very long time. So thank you. But Liz, before you leave, I wanted to ask you a question. Kirk, you're welcome to stay, but Dr. Mumper actually attended the HHS roundtable on Lyme disease in DC on Monday. So Liz, I thought it would be interesting to talk about some of your observations and what you learned from that roundtable.
Yeah, I thought it was great. So first of all, Secretary Kennedy acknowledged the fact that patients with chronic Lyme have often been gaslighted, told their symptoms were psychiatric, didn't really get medical care, how difficult it was for them to get a diagnosis. There were patients there that waited 10 years to get an accurate diagnosis. They had clinicians at the table that were experienced with treating Lyme, and they drew attention to the neuropsychiatric aspects of it and how debilitating it is in terms of the fatigue. They had some really interesting scientists from MIT that were doing really excellent work trying to make the diagnostics better. There's been an ongoing battle between Lyme literate physicians, like in the organization ILADS, versus the traditional infectious disease associations about how many bands need to be positive to call it Lyme. And I think that with the new nanotechnologies and the work that's being done at places like MIT, we are likely to get better diagnostics soon. What wasn't covered as much as I would have hoped was innovative treatments,
Right.
because there are so many people with Lyme disease who don't get adequate treatments. Most doctors know how to do the initial acute treatments, but the America isn't very good at dealing with chronic disease compared to acute disease.
Mm.
And I left feeling very hopeful that, as Kirk would say, the right questions were being answered and everybody was open about talking about it. So Dr. Oz was there, Dr. Bhattacharya was there, Secretary Kennedy, several senators, in addition to the patients, clinicians, scientists, and government workers. So it was well worth the afternoon.
That's great. Well, we appreciate you taking the time to go and represent IMA. Well, thank you both for attending tonight. We're just going to do some quick business announcements, and we'll get back to everybody. We're actually not going to have another show until after the beginning of the year, given all the holidays fall on Wednesdays for Christmas and New Year's. So we'll be back with exciting updates early in January. So thank you both for your help tonight.
Thank you, Kelly.
A pleasure, Kelly, always.
Okay. Thank you. Have a good Merry Christmas and Happy
Merry
New Year.
You too. Bye-bye.
All righty. Well, we're
Thanks.
going to go to the first thing is we've got lots of questions about our conference coming up. So yes, we are having the conference. We're going to have it in the middle of April, April 17th through 18th, and we'll be in the Dallas-Fort Worth area. So here you can see the link on the slide and I'm sure our team is posting it in the chat as well. But we'd love for you to consider making a trip. It's going to be very focused on medical education. And right now we're working with Dr. Varone to build out the full agenda and have a number and hopefully be able to announce our key topics very soon after the beginning of the year. It's also a great holiday gift too, as an option too. So you can go to imahealth.org/conference for details. And then Jenna McCarthy wrote a great article this week, and it was on this is a different slide, but we've got Jenna wrote an article on vaccinating your pets. So that's actually in our Substack. If you guys go to our Substack, everyone's rethinking vaccinating their animals right now. So she has a great overview of that that's available. And then the third item that we'll go through is we have a holiday gift guide, and our editorial team put together great ideas for last minute gifts, really promoting health, vitality, and a way to kind of give with an IMA values. So go ahead and check that link out as well. And as we get to the end of the year, we know that many will be traveling over the next couple of weeks. We actually have holidays hitting on Wednesdays this year, and our team will be traveling too and trying to spend some time with family. But we did want to just say that we appreciate you all, and that we hope everyone has a lovely holiday. We'll be back with vigor on January 7th, ready to launch new topics and new episodes. But one thing that we wanted to leave you with before we go is that we've been doing great work on building the trusted referral network. Dr. Milhoan mentioned tonight that trust in healthcare is broken. We've talked about that. He said today it's a collapse of doctors across, a collapse in trust of doctors across the board. And we agree. And that's part of why we're trying to put together the infrastructure and the resources to build a broader network, and broader than we've even had in our provider network in the past. So again, remember that the end of the year is a tax deductible gift, and we appreciate anyone that can help us and to build that next stage. You can go ahead and give at imahealth.org/restoring-trust. I have one more important ask for you. Many people ask and they say, I've given financially or I can't afford to give. How can I help in other ways? And one important way that you can help is by sharing this important video. We're trying to develop a video and outreach for people who've never heard of FLCCC or IMA and introduce them to an organization that is built on trusted evidence-driven medicine. And many people are recognizing that there is a healthcare system that is broken. So we're going to tee up for you today and premiere a new video. And we'd love for you to go ahead and share this and have our Army help build IMA's following to the next level. And we'll share a link in the chat for YouTube. Yes, we're on YouTube, if you can believe it. And we'll see how long we stay there with these different videos. But we're also always posting on Rumble and Odyssey. And we hope everyone has a very delightful holiday season. And we'll end with a special message from both Dr. Joseph Verone and Dr. Paul Merrick. Thank you all. Have a good New Year's.
Right now, more than 100 million Americans are suffering. Corporate interests drive treatment protocols. The pharma industry is booming, yet patients are left feeling unheard, searching for answers. During the COVID era, physicians who asked questions were silenced, fired, or canceled. Most Americans know we can do better. Meet the Independent Medical Alliance, a nonprofit attempting to restore medical freedom in America, supported entirely by people who believe in patient-first healthcare. At IMA, we call it honest medicine. Root cause, evidence-based, nutrition-centered, and individualized care focused on restoring real health. IMA is the alternative to corporate medicine. Prevention-first education for physicians. Clinician-developed treatment guides for suffering patients, from cancer to insulin resistance to brain health and beyond. Now we're building the Trusted Referral Network, a verified directory of independent, like-minded healthcare clinicians and providers committed to ethical, patient-first care. The IMA doesn't get funding from government grants or pharmaceutical dollars. Rather, from like-minded supporters. People like you. If you believe America deserves patient-first healthcare and honest medicine, we invite you to stand with us. Every tax-deductible gift supports educational programs, real research, and the expansion of the Trusted Referral Network. Support this mission by donating online. For donations of $1,000 or more, connect with our major gifts team. All donations are tax-deductible. Thank you for standing with us and reviving patient-centered medicine.
Hi, we're in Houston, Texas, in my office where Dr. Paul Merrick came to visit and help really to...
Yeah, help Joseph out. You know, we're coming to the Christmas season and I thought I would just help him out and Santa Claus.
I mean, so much vaccine-related injury, so many changes. This year has been a very interesting year, Paul. I don't know if you've seen all the things that are going on in Washington. It seems that we have some momentum. We're actually improving, and the Independent Medical Alliance is doing a lot of really nice things. We are building a trusted referral network. We have the Journal of Independent Medicine, and we have the fellows.
Yeah, so we have a big fellowship program with, over 50 fellows from multiple disciplines, all contributing, and it's growing. So the IMA is the path forward, and it's based on honest medicine, because that's what we need to restore. And in this festive season, it gives us some hope.
And it's interesting because, it started as just some friends trying to help each other do the best for patients. In the process, we realized how corrupt the medical system was, how many issues were in the medical system. And with your help, we've been able to grow. We have grown to have more than 12,000 healthcare providers. We have more than 1 million followers. And we are trying to come up with solutions to a very difficult problem. So during these holiday seasons, I have to say, Happy Hanukkah.
Merry Christmas.
And we wish you a Happy New Year. We could not do all of this without you.